The next speaker is John Curry, talking about evidence-based approaches to treatment of depression. Dr. Curry is a professor of psychology and neuroscience at Duke University. His interests include child and adolescent psychology, psychological testing, group psychotherapy, individual psychotherapy, CBT, adolescent depression, and substance use. He's long been one of the leaders in the field of CBT for treatment of depression in children and was one of the lead investigators in the TADS study, Treatment of Adolescent Depression study, which is the largest and most influential study in the treatment of depression. He'll talk about that during his talk today. So he knows just about everything there is to know about treatment of depression from multiple perspectives. The TAD study included medication as well as CBT, for example. John earned his degree from Catholic University of America in 1978, and we appreciate his having taken time out of his busy schedule to come and give us a talk. So please help me welcome Dr. John Curry.
Thank you. It's very nice to be back in Florida. Okay, so I'm going to talk about depression, and I had an experience once giving grand rounds in a department of pediatrics where I spoke for an hour about the treatment of depression, and at the end of the talk, one of the pediatricians asked me, yes, but what do you mean by depression? So I thought I never forgot that. It was one trial learning. So I always start by saying what I mean by depression. And I'm going to be talking primarily about depression as a disorder, namely major depression, although a lot of the findings will also pertain to kids with milder forms of depression. And just to review, depression is categorized as a mood disorder in the current diagnostic system. There are both depressive disorders and bipolar disorders, and of course bipolar disorder includes mania as well as depression. These are the symptoms of depression. Just for your review, to get a diagnosis of major depression, you have to have 5 of these present for at least 2 weeks. Those of you that worked in clinics, I doubt that very many of you have ever seen a depressed kid who's only been depressed for 2 weeks, but that's the minimum. So there are mood disturbance, anhedonia, lack of pleasure, physical symptoms like weight or appetite problems, sleep problems, psychomotor agitation or retardation, which is less common than the others, but still can be present. And if you work in an inpatient setting, you'll definitely see kids who are agitated or slowed down. Fatigue or loss of energy. So a lot of physical symptoms, somatic symptoms of depression, as well as cognitive symptoms, thoughts of guilt or worthlessness, diminished ability to concentrate, which usually shows up in school performance, and suicidal thoughts or plans or behaviors. This is one of the psychiatric disorders which can be fatal. So that's why you'll see that there was a push. When I talk about TADS, you'll see there was a push by the NIMH to get some practical findings out to the community, even though the field wasn't that far developed yet because of the severity of the problem and the prevalence. So how prevalent is it? This is the most recent survey of prevalence that I have found by Jane Costello and Adrian Angold and Al Arcanley. They studied 26 individual studies and combined them, and they found that the prevalence for children is about 2.8%, and it goes way up in adolescence, as you know, especially among girls, where it reaches 6%. And it's actually pretty high in boys. We often think it's much more high in girls, which it is, but it's still pretty substantial in boys. So this would mean that in a typical high school, you know, if you think of high schools, I went to a parochial high school, so it's not that hard for me to think of a class of 100 kids in the class, you know, or 1,000 in the entire class. This is a lot of kids. Okay, it'd be about 5 or 6 out of every 100 kids who have major depression, either currently or recently. Now, one of the things you have to keep in mind when you're looking at treatment for depression is that it's an episodic disorder. So unlike the general trend in treatment outcome where after treatment ends, there's a bit of a worsening, which John showed you in his meta-analytic slides. In depression, when treatment ends, people typically tend to continue to get better. And you'll see that in some of the studies that I show you. That's the good news. So the median duration in children is 9 months, and in community adolescents, it's about 6.5 months. Well, the mean is about 6.5 months. But there's a high rate of recurrence. So recurrence can be as much as 50%. In Kovacs's child sample, it was 54% in just 3 years. In the TAD sample, which I'll talk about later, it was 47% in 5 years. So a lot of kids are going to have recurrent episodes. And there's a high risk that they will then have episodes as adults. I just cited one study here. There are many studies that show this. This is one of the longer ones where Harrington and his group in England followed kids for 18 years and found that the ones who came to a child psychiatry clinic as children for depression were 4 times more likely to have depression as adults than other kids who came to the clinic. So this is not compared to non-disturbed kids. This is compared to kids who have non-depressive problems in childhood. And as John and Chuck talked about before, there's the issue of comorbidity. Again, I'm sure if you work in a clinic, you've rarely seen a depressed kid who only has depression. Most of the time, there is anxiety or some kind of behavioral or substance abuse problem as well. The pattern is typically that anxiety comes first before depression developmentally. Not always, but most of the time. Conduct disorder usually comes first. Substance abuse can come either before or after depression. And the comorbidity of major depression with conduct disorder or substance abuse is particularly dangerous in terms of raising the risk for suicide attempts either later in adolescence or in young adulthood. And of course, any comorbid disorder complicates the treatment of depression. So that's kind of background on the disorder. So you have a disorder that's very, very common in adolescents that tends to be episodic. If you don't do anything, it'll probably get better, but it won't get better that fast. And it's often recurrent. So one of the things we want to try to do is develop treatments that will prevent recurrence. So I want to talk in the rest of my time on the evidence base for treatments of adolescent depression. What practices, what psychotherapies, and what combined treatments. By combined treatments, I mean psychotherapy combined with medication. And I want to spend a little time talking about what kinds of evidence we have, because it really varies a lot across the different treatments. I'm not going to include a review of medication only. I'll only talk about medication in a couple of studies where it was combined with psychotherapy. But you could do a pretty substantial review of the evidence in support of several medications for adolescent depression. So to give you the bottom line first, there are 2 psychotherapies that are considered established evidence-based treatments for adolescent depression. One is interpersonal psychotherapy, and one is cognitive behavior therapy. As you saw in the presentation that John Wise did first, there are many more studies of cognitive behavior therapy, but there are several studies of interpersonal psychotherapy that raise it to the level of, I would say, established in the sense that at least we know that it's better than certain other non-interventions or minimal interventions, and equivalent in one study to CBT. The established combined treatment is CBT and fluoxetine from the TAD study. And then I will talk about, for a minute, a promising innovative therapy, which is attachment-based family therapy. I couldn't decide whether to talk about this first or last, because usually I talk about innovative, promising things at the end, but that would kind of come after a whole buildup of evidence in these other areas. So I decided I'd just talk about it first. I think it's an interesting study, and you'll see when we do the review of IPT and CBT that we certainly need to be looking for innovative treatments. So attachment-based family therapy has been developed by Guy Diamond and his colleagues at Temple and Penn. And the idea here is that repairing the adolescent parent attachment will alleviate the depression. That's the core idea of attachment-based family therapy. His first study was a small pilot study of 32 mostly female, mostly African-American adolescents in Philadelphia who all had major depression. And they were randomized to either 12 weeks of treatment or a 6-week wait list. At the end of the time of these two treatments, 81% of the kids no longer met the criteria for major depression after having had attachment-based family therapy. You'll note that 47% of the kids on the wait list also did not have major depression after their wait. Now, this is why it's tricky to do treatment studies of depression, because it is episodic and it does tend to resolve. So you really need to pay attention to who the participants were in the study when you start to evaluate the treatments. You know, how likely are they to get better spontaneously? Okay. But 81% is a whole lot better than 47%, so it certainly is encouraging. More recently, they've published a paper on kids with suicidal ideation, 66 adolescents who were referred to them from primary care or emergency room settings in Philadelphia, 70% African American. They received either 3 months of attachment-based family therapy or enhanced usual care, which included weekly monitoring and access to a crisis phone. And at the end of the 3 months, the kids who got the attachment-based family therapy had done better on the rate of change in suicidal ideation, recovery from suicidal ideation, and change in depressive symptoms. This paper is published in the Journal of the American Academy of Child and Adolescent Psychiatry. So I think it's a promising intervention. I would like to actually compare it to CBT, and we're trying to do that. Now, to go to the more established interventions, the first one is IPT for adolescents. Now, IPT, as you may know, was developed out of kind of traditional American psychiatry, Harry Stack Sullivan's model of psychiatric intervention. And it was manualized first for adults in the NIMH collaborative study of treatment of depression back in, I guess, around 1990. I forget the exact year. And then it's been adapted for adolescents by Laura Mufson. So the idea here is whatever has caused the depression, it is being maintained by problems in interpersonal relationships. And one of these 4 categories is considered to be the key issue and the key focus for any given adolescent. A loss or grief, a role transition. You can think of some of the role transitions of childhood. For some reason, I can never forget the role transition into middle school. That's one of the worst. Interpersonal role disputes where you get into an argument with a parent or a teacher, or interpersonal deficits where you lack social skills. And what the interpersonal therapist does after a diagnostic assessment is an interpersonal inventory about the relationship that the teenager is having, and then they focus on one of those 4 areas of treatment. The treatment consists of encouraging emotional expression, exploration, problem solving, and resolving the focal problem. I find this a very attractive treatment. I like it. I think it's common. It's similar to what most of us were trained in or already do. You know, and it makes sense to people. So in the early study, Laura Mufson and her group compared it to clinical monitoring. Now, clinical monitoring, of course, is a very minimal control group. It would be like what John talked about as a non-active control group. The kids are simply monitored on a regular basis. 48 teenagers, of whom 33 completed the study, mostly female and mostly Hispanic, living around the area of the Columbia Medical Center up in Manhattan. They all had major depression. They got 12 weeks of treatment, or they got once or twice a month monitoring. At the end, the IPT for adolescents was superior to the clinical management in reducing depressive symptoms. 75% of the treated kids were free of significant depressive symptoms. That's a very high rate, as you'll see as we go through other studies. But 46% of those who simply got monitored were also free of significant depressive symptoms. Okay? IPT in a somewhat different version has been applied in Puerto Rico in a study by Rosello and Bernal with 71 Puerto Rican adolescents with major depression who got either IPT, CBT, or a wait list for 12 weeks. And at the end of that time, both of the active treatments were better than the wait list on self-reported depressive symptoms. IPT was also better on self-esteem and social adaptation. Interestingly, when parents were asked, there was no effect of any treatment. Parents didn't think anything had really changed, okay? More recently, the New York group they have a lot of studies, but a lot of them are not controlled trials, so I'm only talking about the ones that are randomized controlled trials. This one was in schools. So here the question was, well, can school guidance counselors and school psychologists be trained to deliver this treatment in schools? So they saw 63 kids at 5 schools in New York. Again, mostly female, mostly Hispanic, mostly major depression, but a few with milder diagnoses. And the IPTA was administered by school clinicians for 12 to 16 weeks. Okay? Otherwise, the kids who were randomized to the control group got treatment as usual, which would be the standard counseling that the school psychologist did. So this is an active control group, okay? Much different than a wait list or clinical monitoring. And still, the IPTA did better than treatment as usual, TAU, treatment as usual, on interviewer-rated depression, self-reported depression, functional impairment, and severity of depression. So it was quite encouraging. So what I would say about IPTA for adolescent depression is that it's been proven to be superior to clinical management, superior to treatment as usual. The limitations are the samples have been very heavily female and Hispanic, which is fine. It's the reverse problem of what we usually have. We have to see if it generalizes to other ethnic groups. No comparison yet to active medication, pill, placebo, or combined treatment. The effectiveness test was targeted toward a more challenging setting, not toward more challenging cases. I'm going to show you at the end how the history of the CBT has been more towards more challenging cases, not necessarily more challenging settings. So let me get into CBT now, and I'll be talking about that for most of the rest of the time. This is kind of a gross oversimplification, but You could argue that there are two theories of CBT that underlie the studies I'm going to go through with you. One of them is the Beck model, the cognitive therapy model. But the basic idea is that stress triggers some negative core belief that you have been carrying around within you since childhood. And it can be something like, I am unlovable or I am incompetent. And that's manifested in these dysfunctional, conditional beliefs like, unless everybody loves me, I'm not lovable, and negative automatic thoughts. She doesn't like me, and other depressive symptoms. So in cognitive therapy, you really want to go after the cognition. There's clearly a primacy in cognitive therapy to address depressive cognition. Somewhat by contrast, Lewinson's model of CBT is multifactorial. His argument is that depressed people don't get enough reinforcement. They don't get enough positive reinforcement, and they don't get enough social reinforcement because they're socially withdrawn and they're caught up in negative thinking. So they don't go out and do things with people that would be rewarding, and they withdraw and spiral down into negative thoughts, negative mood, and social withdrawal. So there's really not a primacy on cognition in the Lewinson model. You can go after cognition, or you can go after behavior, or you can go after problem solving. Okay? And so that affects differences in therapists' behaviors. All CBT therapists do a diagnostic assessment and a cognitive and behavioral assessment, and then they either do an individualized case formulation, which is probably what most of you do in practice, or they use a set of standard procedures to elicit and then modify negative behavior patterns and thoughts. Okay? So I'm going to go through a little history here, because this is a field that has enough in it that you can do a little history. It doesn't have a great deal, but it's got enough that you can sort of look at it historically and show you where we are. So I'm going to break it into three categories: the early studies, the studies in the 1990s, and the studies since 2000. The early studies were school-based. So Bill Reynolds and others worked with kids in schools who had depressive symptoms. These were not formally diagnosed patients with major depression. They were kids who had elevated scores on symptom scales. I think it's pretty clear that a lot of them would have had a diagnosis if you look at the scores they got. They were group interventions, and they were small samples. So the first study that I could find was 5 weeks of CBT, or 5 weeks of relaxation training, or 5 weeks of a wait list. And the sample size was 30. Now, I don't know how many of you write grants, but if you try to get a 3-group study with 30 subjects past a review panel these days, good luck, okay? It's not powered enough. There's not enough power in the numbers to detect differences between active treatments. But anyway, it was a breakthrough study. This was the very first study of depression in adolescents, treatment of depression in adolescents. And they found that the CBT and the relaxation were equal. The CON study was similar. It was 6 to 8 weeks of CBT. These were twice-a-week groups, compared to a self-modeling and a relaxation and a wait list. So they had 4 groups with 68 kids. And they found that all 3 active treatments were equal, and all were better than a wait list. So these early studies prior to 1990 showed that CBT was better than nothing, which, remember, even with nothing, a lot of people are going to get better. CBT was not superior to the alternative interventions. But they were very underpowered to detect any differences between the active treatments. That's been kind of a development since then in the field of clinical trials. So then we go into the 1990s, and you see a different kind of study being done. Here, the main studies in the United States were with diagnosed depressed adolescents. There were some British studies too, but I didn't include them because just to try to keep it streamlined. They were smaller. There's a movement here towards larger samples and more clinically relevant samples. If you're working in a clinic, like a mental health clinic or a private practice, you could reasonably say those early studies might not be with kids like the ones I'm seeing. Maybe they would be, maybe they wouldn't be. But these kids now you start to see really are depressed. So there were 2 studies in Oregon and 1 in Pittsburgh. The Oregon studies were based on Lewinson's model. No surprise, because he was, guess where? Oregon. Okay, so his student, Greg Clark, did the first study. It was his doctoral dissertation, which, you know, that's pretty impressive, I think. Greg also did the second study with Lewinson and Paul Rohde and other people at Oregon. And that was a coping with depression course. This is a group, highly structured group intervention where everybody gets the same skills trainings over time in a group. And it was presented as a course, like a psychoeducational intervention, which made it more palatable for a lot of the kids. They could come and take this course. They didn't have to go see a doctor for treatment. The Pittsburgh study, on the other hand, was cognitive therapy. David Brent was a student of Beck, and he took this to Pittsburgh, and he was the first to try cognitive therapy with adolescents. So I want to go through these 3 studies. So here's the first, the 1990 study. 59 kids, adolescents between the ages of 14 and 18, and they got 14 2-hour groups over 7 weeks. For half of them, there was also a parent group. The parents were invited to participate in a psychoeducational group, which mostly dealt with what were the kids learning, what skills were the kids learning. And those 2 conditions were compared to a wait list. Most of the adolescents, or about half of the adolescents had major depression, but the others had milder forms of depression. And they looked at depression diagnosis at outcome, and the outcomes were that very few of the waitlist kids were free of the depression at the end of the 7 weeks, only 5%, compared to 48 and 43% of the kids in the 2 active conditions. And the numbers are a little higher when the parents were involved, but not significantly higher. They followed them for another 6 months, and of the treated kids, 82% of them were better at 6 months. So this is what I'm saying. They get better after treatment ends if it's depression. Okay. Now, the second study, where Greg Clark is the lead author, was a little bigger, 96 kids, but basically the same design. They extended the treatment for 8 weeks. They extended it by 1 more week, from 7 weeks to 8 weeks. And at the end of that 8-week period, check the numbers, okay? The numbers are higher in all 3 conditions. So the treated kids go up to 65 and 69% no longer depressed, but 48% of the waitlist kids were no longer depressed. Now, this kind of screams out to me that these were different samples. That's what happens when you do clinical trials and you recruit for samples, you get differences just by chance. It looks like the first group was more severely depressed in some way than the second group, or more pervasively depressed or something, okay? Once again, the parent involvement did not affect the outcome. The third study by David Brent and his colleagues came out in '97, and this was the most clinically representative sample, I think, that these kids were truly all majorly depressed with functional impairment, and they were assigned to one of 3 conditions: non-directive supportive therapy, that's Rogerian therapy, which is not to be confused with Albert Ellis, which is non-supportive directive therapy. Maybe this joke's getting too old, I don't know. or systems behavioral family therapy, which was Robin and Foster's model of family interactive behavioral therapy. They got 12 to 16 sessions over 12 to 16 weeks, and the outcome was whether or not they were free of major depression and had 3 consecutive normal Beck Depression Inventory scores. And these are the remission rates at termination based on those criteria: 60% for cognitive therapy and 38 and 39% for the other 2 conditions. Okay? So the cognitive therapy was significantly better and faster than the other 2 treatments. They also looked at questions relevant for clinicians beyond just a clinical trial. Did the kids need more than this? And they found that during treatment, 11 to 14% of the kids in the 3 conditions also received additional treatment of some kind. Could be medicine or could be family intervention or something. And those kids tended to be more severely depressed and more likely to have dysthymia. So dysthymia is a low-grade, persistent depression that goes on longer than major depression. During the 2-year follow-up period after treatment, 49, 37, and 40% of adolescents continued to obtain additional treatment. They tended to be more severely depressed or have disruptive behavior disorders or family conflict. So for many kids, the bottom line is 12 to 16 weeks of depression-focused cognitive therapy is not going to be enough to resolve all the issues. 2-year follow-up, 84% of them had recovered, and there was no difference in recovery rates across the 3 treatments. 30% had a recurrence within 2 years. So good recovery rates, but significant rates of a second episode within just 2 years. Okay? So the 1990 studies tell me that CBT is effective, better than alternatives. It's not clear how to include parents, and outcomes may depend on samples. Now I want to go to 3 studies since 1990, TADS, Tordia, and ADAPT. And the way I look at these, they deal with progressively more difficult cases. TADS kids were all moderately to severely majorly depressed with functional impairment. Tordia were kids who had failed a medication trial. This is treatment of resistant depression. And ADAPT was a study in the British health system where there were hardly any exclusion criteria. No matter what else you had, if you had depression, you got into this study. I want to acknowledge my PI, John March, and colleagues at Duke and UNC and NIH, as well as Greg Clark and David Brent for the TAD study. And the site, there were 13 sites. And these are the principal investigators at each of the sites. Some of them are double sites, so I guess I only have 11 bullets, but some of them are double sites. TAD studied 3 stages of treatment: 12 weeks of acute treatment, 6 weeks of what we called consolidation, and 18 weeks of maintenance treatment. The treatments were fluoxetine, placebo, CBT, or combination of CBT and fluoxetine. The placebo ended at week 12. This is the visit of dosing and office visits for either fluoxetine or placebo. So placebo is not to be confused with driving by the Rite Aid drugstore and picking up a pill. It is a visit with a doctor and review of symptoms and so forth, just like as if you were taking an active drug. The CBT, which I'll talk about in the workshop the next couple days, combined elements of both the cognitive and behavioral models. I want to acknowledge Karen Wells, who was the primary author of the Family Manual. And this is what was in the CBT. I'm not going to belabor this in the interest of time, but just so you know what elements, because, you know, as we talked about earlier, and both of the previous talks discussed the importance of figuring out what are the key elements you need to have in the treatment. So this was what we thought we needed to have as of the year 2000, when this thing started. monitoring mood, setting goals, increasing pleasant activities, problem solving, and cognitive restructuring. There were also optional elements that therapists could use to target the treatment toward individual kids' needs. Relaxation, affect regulation for the more impulsive or self-harming kids, and 3 social skills modules. The parents had to be involved in psychoeducation and also in at least 1 interactive session. And these were the optional interactive sessions. So again, the therapist decided on these based on the problem, and they could convert individual sessions to family sessions if they thought that was indicated. Now this is a big sample. It's 439 adolescents with current major depression, at least 6 weeks of depressed mood and functional impairment in 2 out of 3 settings. It was 74% Caucasian, 12% African American, and 9% Hispanic, which back then actually was an accurate reflection of the general US population. About half female, lots of comorbidity, especially anxiety disorders, ADHD, and oppositional defiant disorder. The mean episode duration was 19 months. So you can see that these kids have been depressed for a long time. The median was 10 months, and the global assessment of functioning was 49, which is, pretty low, but suitable for outpatient. Now, I'm going to show you some results, and you'll get a chance to, I'll get a chance to practice my cognitive restructuring skills when I show you these results. So how did they do in terms of severity of depression and general improvement? So this shows you that this line here is the best outcome. This is combination treatment. This is fluoxetine, and this is CBT and placebo. So the CBT did not beat the placebo. The combination treatment was superior to all 3 of the other conditions. So as a good cognitive therapist, I don't pay attention to the fact that the CBT didn't beat the placebo. I pay attention to the fact that the combination treatment beat everything else, because that included CBT. That's pretty good, right? I didn't even need fluoxetine to do that. What were the better outcome predictors? Being younger, being depressed for less time, better global functioning, less suicidal, less hopeless, no anxiety disorder, higher expectation for improvement with the treatment that you got. The moderators were, combination really only helped, at week 12, combination only helped moderately severe kids. It did not surpass medication alone for severely depressed adolescents. And it also was only useful when there was actual cognitive distortions. So if the kids didn't have cognitive problems, the cognitive behavior therapy did not surpass fluoxetine. One of the most intriguing findings, which we have no way of understanding yet, is that CBT was just as good as combination if the kids came from high-income families. I would like to get your thoughts on this. I don't understand it. It was not IQ. It was not vocabulary score on the WISC. It was related to family education, parents' education. Now, let's look at improvement, because we go beyond 12 weeks. So at 12 weeks, these are the numbers that were reported in the original paper in JAMA, and this was based on carrying forward the improvement ratings from week 6 if the kid didn't show up at week 12, okay? So those are your improvement percentages, significantly improved. It's quite high in combination. What happened after week 12? Most of the kids stayed in the trial. The placebo kids got treated. Most of the other kids stayed in the trial unless they had been complete non-responders, in which case they were referred out, but they still stayed in the assessments. And this is the graph of what happens out to week 36. So you see that everybody gets better, and everybody kind of converges out here at week 36. The CBT is slower, especially in the beginning, and then the slope is pretty much the same. Well, it's a little bit slower here. Medication gives you a faster response, but you all end up at the same place at 36 weeks. Now, 36 weeks is a long time, it's 9 months. If you look at improvement, this is interesting. An improvement at week 12, this is based on a different statistic called general estimating equations. Once you have all the data over time, you can go back and estimate how many of those kids really were improved who didn't show up for the week 12 assessment. And the numbers are a little higher in each case. So almost half of the CBT kids were improved by week 12 on this index. And here's what happens after that. There's week 18. So by week 18, the CBT catches up with the fluoxetine, but this combination is still better. And by week 36, they're all pretty much the same. Okay? So the gap between the CBT and the fluoxetine closes by week 12 on the CGI improvement. On the CDRS, which is a rating scale, the fluoxetine stays superior until week 24 when it catches up. Combination is the best all the way out to week 24. The bottom line here is if a parent asks me what I recommend for treatment of an adolescent major depression, I recommend combination treatment. I'll give you more evidence. Safety, 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 a big issue with medication studies. Suicidal ideation gets better in all groups, okay? A combination goes down, the most steeply CBT goes down, the next best, and the two pill arms are a little slower. What about actual suicidal events? This is an attempt, a preparatory action leading to an attempt, or serious ideations, so to the extent that either the parent or the clinician takes the kid to see the doctor or the emergency room. It does not include self-harm like cutting or burning. It's really suicidal, okay? Here's a percentage of patients with a suicidal event by week 36. And you can see that the combination, which is the one on the left, seems to offer some protection against suicidal events compared to fluoxetine alone. This is a significant difference. So there is an elevated risk of a suicidal event in a medication condition. It's a small risk, but it is there, and it looks, from TADS, it looks like CBT can mitigate that. It's another reason I recommend combination. So these are the safety conclusions. CBT is safer than fluoxetine, but it's slower. And you do want the kid to get out of the depression. And if you combine the two, you get the advantage of a faster, more complete response for depression and a greater degree of safety. But remember, the safety is not absolute. Combination was also better in terms of cost effectiveness by week 36. At week 12, fluoxetine was the most cost effective, but if you followed them out to week 36, combination is most cost effective because the kids who only got fluoxetine had more events like emergency room visits and outpatient care than the kids who had combination. Now, I'm just going to talk briefly about Tordia and ADAPT. Tordia was a tougher sample than TADS. These kids had already failed 8 weeks of medication treatment. They had not gotten better. So they were randomized to either get CBT or not, and to either get a different SSRI or venlafaxine, which is Effexor. I could give a whole talk on the adventures of dealing with safety issues and the FDA during TADS and Tordia, but it was kind of a moving target where some of these evidences were coming out about risk, and they had to adjust these. But this was the final design. The Tordia CBT was similar to the TADS CBT, but there were less rigidities in it. It was more flexible, and it added more emotion regulation. After 12 weeks, there was a higher response rate in kids who got CBT than in those who didn't. So this is a second argument for combination treatment. There was no difference between whether you got a different SSRI or you got Effexor. Okay. And then ADAPT. ADAPT is a British study, 208 adolescents in the National Health Service. They were already getting fluoxetine and standard counseling. And the question was whether if you added CBT to those two treatments, would you get a better effect? They followed the kids for 28 weeks, and overall 57% were responders, but there was no additional effect of CBT over the other treatments. So in the British health system, that would be an argument that you don't really need to add yet another treatment if you're already doing these two with this population. So in summary, here's the way I see things at the moment. CBT has been tested far more than any other psychotherapy for adolescent depression. The second most extensively tested one is interpersonal psychotherapy. It's been shown that CBT is better than a wait list. It's also been shown that it's better than two alternative psychotherapies in the Brent study, supportive therapy and systemic family therapy. It did not prove to be superior to clinical management with a placebo. No other adolescent psychotherapy has made this comparison. And it's in the adult literature, there are only a handful of studies where either CBT or cognitive therapy did surpass a placebo. I found 2.5. So in two studies, it clearly did it. In a third study, it did on one measure and not the other. It's a tough comparison. It's slower than fluoxetine. It's also tough for medications to beat it. You know, if you do medication studies, a lot of them can't, for depression, a lot of them don't succeed in surpassing placebo. But fluoxetine does. CBT is slower but catches up, and it lowered the risk of suicidal events in TADS. It didn't add to the routine care and medication in ADAPT. And in TADS, in the first 12 weeks, it did not add to fluoxetine for the most severely depressed adolescents. For depression, it might have helped them with suicide, though. Okay. Combining CBT and fluoxetine gave the optimal outcomes in TADS for depression, global functioning, suicidal events, and cost effectiveness. And in Tordia, when it was combined with either a different SSRI, different than the first SSRI the kids were on, or Effexor, it led to better response than medications alone. So where do we go from here? One thing we really need to do is to identify, within CBT, we need to identify what are the essential elements. It's almost certain that we had too many elements in the TADS CBT. Or maybe we just didn't have good enough ways to decide which elements needed to be provided to which kids. One issue is whether a simpler therapy is more effective than a complicated therapy. Okay, so I don't know the answer, but that's an issue. Clarify how to involve parents. This is really a mystery. The clinical trials don't give us much help in figuring out whether and to what extent parents should be, or how parents should be involved in the treatment of adolescent depression. You saw earlier that there is some evidence that when parents are involved in the treatment of anxiety disorders, it makes a better outcome. But in the depression studies so far, that hasn't been tested very much, but when it has been tested, it hasn't shown up. I think the slow speed of response of CBT, at least in TADS, indicates that we need to do something to streamline the beginning of the treatment. It takes too long to get it going. There's too much psychoeducation. It doesn't jump right into where the kid is in terms of what they're concerned with, and I think that is something we need to work on. And then I think we need to focus on alternative models like attachment-based family therapy or interpersonal therapy, and try to continue to develop innovative methods to treat this important and difficult condition. We need to get treatments that work faster. We also need to get treatments that prevent relapse. So far, we do not have any treatment that prevents relapse. We followed the TADS kids for 5 years. I mentioned a moment ago, about 47% of them had a second episode within 5 years, which is really, I mean, it sounds bad, but it's really better than some of the earlier follow-up studies in terms of speed of relapse. But none of the treatments made any difference. It didn't depend on what treatment you got, whether you had a relapse or not. So none of the treatments stood out as relapse prevention. That's a big issue that we need to deal with. Okay, thank you.